You can either get these treatments in clinical trials, or you can get them outside of clinical trials. And I'll just give you a couple of examples. If you've got brain metastases, but you don't have any metastases in your body, it is not standard of care to increase the TKA dose, but it is definitely care that's being done quite commonly by some of the leading ALK experts. Similarly, if your cancer has been greatly reduced by the TKI, it's not standard of care to get consolidation therapy to try to either even further reduce by radiation or surgery the remaining tumor. But again, there are quite a number of leading experts that will do that treatment on a regular basis. And then there's a ton of clinical trials, and we'll be talking about some of those. So we were hoping to be having Dr. Lynn here in person. Unfortunately, at the last moment, she got a scratchy throat and some other symptoms, and she did not want to be amongst a bunch of lung cancer patients presenting like that. So she's going to be doing this virtually. I can see you there, Dr. Lynn, so hi. We have with us also remotely Emily Venanzi. She also was going to be here in person, and her son managed to get COVID, and so he's been relegated to the basement, and she's, for the same reason, caring for us, didn't want to come here and put us at risk. So thanks, Emily. We have here with us Ray Hall. Ray Hall was working with Novartis for 40 years. So he knows a thing or two about clinical trials. We have with us JP Noonan. JP is also on the clinical trials committee. JP works for a very, very large, counted in billions of dollars, many billions of dollars, pharma company, and she is lead for clinical trials. So JP also knows a thing or two about clinical trials. Marc Muskavitch is also a member of the clinical trials committee, and Marc was a full-time professor in cell and gene therapy. So he knows a thing or two about cells and genes that I don't understand. As a patient, we have Frank Sierawski, and Frank will be telling us his story in a little bit, but Frank was diagnosed in 2014, and he hasn't aged one day since then. It's been 8 years, and I think it's something to do with alectinib, stops you from aging or something. I don't know what it is. And then we've got Nathan Plattner, and Nathan is clinical trials coordinator at University of Colorado, working with the Dr. Kamich team, and he'll be able to help answer any questions that you have also. So with that, and we do, I'm sorry, and I don't know if we've got Jeff Sturm on the screen there, but Jeff was not willing. He's got fairly advanced stage 4 cancer, as does his wife, and so he wanted to play safe and not come in person. So I'm going to kick it off by asking JP to answer the first question, and then it'll be sort of an open panel discussion amongst all the panelists. So we hear about phase 1 and phase 2 and phase 3 clinical trials. What does that all mean? What is the purpose of clinical trials, and how do they work? And we hear about exclusion criteria and inclusion criteria. What does that all mean? And also hear about compassionate use and consent forms. So if you want to kind of fill us in on all of that, that'd be fantastic.
Sure. So it's such a pleasure to be here. I'm so happy to be up here just to talk a little bit about clinical trials, kind of set everyone, we all have heard these terms. We know some know more than others. Some know, very little about clinical trials. Some know a lot about clinical trials. So we thought we might just take a couple of steps back and kind of have a reset. So we all know what a clinical trial is and kind of some of these bigger terms that you hear surrounding clinical trials. So basically, a clinical trial is just a process that we use to evaluate safety and effectiveness of medications in large groups of people, right? So we have a medication, we think it's going to work for this one indication, but we want to make sure it's safe. So we do that testing. And the way we do that testing is in phases. So we have, and I'm sure folks in the room have heard phase 1, phase 2. We do clinical trials basically in 4 phases. We start with phase 1, which is a very small study. Small study really looking at the safety of a new medication. It's not approved, it's still in testing, but we really want to look at it and make sure that it's safe for humans. So we have a small number of people that participate in a trial, and I'll talk a little bit about trial participation when we get to the informed consent portion. Small number of patients that participate in a study. Sometimes you'll hear dose finding or dose escalation, and we're looking at the safety profile and trying to figure out what dose makes sense to bring forward to subsequent phases. So that leads me to phase 2, right? Phase 2 is a larger study than phase 1. We're always looking at safety, so still looking at and building up that safety profile for the drug, but also kind of bringing in the effectiveness, right? We've established the dose in phase 1. We've looked at safety. We're looking at safety again in phase 2 with more participants, and also starting to bring in that effectiveness piece as well. We might start to see that in phase 1, but phase 2 is really where we start to look at that. Phase 3, then again, a larger study, sometimes called a pivotal study. Here's the importance of a phase 3 study is at the end, when phase 3 is completed, that's the point in time where approval can be, a company can apply for approval. So that regulatory approval to mark a drug actually being out there in the world and used as a treatment. So that's phase 3, at the end of phase 3. We also, you might hear phase 4 as well. The drug has already been approved. However, there are still studies that we'll conduct to continue to look at the safety profile. That's something we're always looking at. We're continuing to look at the safety profile, looking at things in, long term, as well as looking in a much larger population than we had in the clinical trials from phase 1 to 3. So just basically really high level, what a clinical trial is and how we kind of go about the process. I brought my notes with me, fearing that I wouldn't be able to see the screen. I'm going to talk a little bit about informed consent. Informed consent, again, something else that I'm sure folks have heard. Informed consent, certainly if you've been involved in a trial, you have signed an informed consent form, but what does it really all mean? So informed consent is a process. It's not a point in time. It's a process that is meant to educate a potential participant or a participant in a study as to whether they want to join a study or continue to be part of a study. So the signing of the informed consent is what really everyone seems to focus on, but informed consent, again, is a process. It's you hearing about the study, having the opportunity to ask questions about the study, gathering all of the information about the study and what's expected of you, what's expected of the physician, what's expected of the study team, and making that informed or educated decision as to whether you want to join a clinical trial. Kind of speaking again to that process point, clinical trial participation is always voluntary, and that the voluntary nature of the trial means that at any time during the course of the trial, just because you've signed the consent form doesn't mean that's it, I've signed away my life, I have to do this. Absolutely not. You are within your rights at any time during a trial to say, this isn't for me, I don't want to continue. You can have many reasons. You can have no reasons at all. Doesn't matter. Your decision, always voluntary, but you are expected to sign the informed consent form just to document that, that your consent to participate in the clinical trial.
You have something about inclusion, exclusion, and
Yeah, I have eligibility. So just wanted to talk really, really quickly. Any trial that you would participate in, there's what's called the inclusion exclusion criteria. And basically what that means is there are characteristics that need to be true for you to join a trial. And some things that can't be true if you want to participate in the trial. So inclusion, all of the things that need to be true. You need to have a specific disease, your labs are in a specific range, you've signed the consent form, you can come to the visits, you can do everything that's needed for the trial, amongst other things. The lists are quite long. And some exclusion criteria, which also, if these things are true, that precludes your participation in the trial. So there's a screening process after you've signed consent, and all of those things will be gathered by the study team to determine if you can actually participate in the trial. And just one note on inclusion exclusion, it's unique to every trial. So one trial's inclusion exclusion list is different, some overlap perhaps, but is different from another trial's inclusion exclusion. And to touch really quickly on compassionate use, because we hear this a lot. So when a new unapproved drug, this is the thought of making a new or an unapproved drug available to treat very ill patients when no other treatments are available. I wanted to touch on this because this comes up a lot in our group. And basically this requires, it's not available for all drugs, which is, I think, a really important point. Not in phase 1, as we're trying to build the safety profile of the drug. And it really requires quite a bit of coordination between your doctor, the sponsor, regulatory agencies, as well as the IRB to make sure that all of your rights are protected. So just wanted to mention that as well. And I think that's the end of my spiel.
Hello, everybody. Very nice to be here, and happy to meet many of you in person after seeing you on the little squares. Dr. Lin, I hope you're feeling better. I'm going to address this question to you. I think many of us are under the impression, maybe rightfully or wrongfully, that clinical trials are only for patients, maybe after they've gone through the progression of TKIs, maybe chemotherapy, you've exhausted chemotherapy, it's no longer effective. What we'd like to ask, Dr. Lin, when are clinical trials appropriate? Are they appropriate for patients newly diagnosed? Are they appropriate for patients that are, like many in this room, are on first or second line therapy and begin to progress? I think my thought of that has always been that I'd like to see patients go on trials when they're healthier, instead of until they're at the end, they've exhausted the chemo and they're a little bit sicker. So could you speak to that for us?
Yes, happy to. And thank you. I just want to start by saying hello to everyone. I wish that I could have been there in person. I was very much looking forward to it, but I am grateful that this is being done in a hybrid model where we can bring everyone together in person and by Zoom. So I'm very glad that this question is being asked because it is a important one to address. And so this is a good forum to talk about it a little bit. As you heard from JP, clinical trials are really about answering a question about a treatment option in a particular setting, and that can be either in a later line setting or in the first line setting. And the goals are very different, right? So in the later line setting, when you're looking at an investigational therapy, the goal is to really address the disease relapse on an earlier line of treatment and maybe to overcome the mechanism of resistance that resulted in the disease progression. Whereas in the first line setting, the goal is to really maximize the initial response and perhaps prolong the duration of time that you have benefiting from a given treatment regimen. Now, it's generally true that more clinical trials are available in the later line setting. And in part, that's because we do have a generally highly effective standard first-line options, right, for ALK-positive lung cancer, which is ALK inhibitors, right? We know that these ALK TKIs tend to have good response rates in general, that they tend to be well tolerated. So the bar in thinking about another treatment regimen in the first-line setting is generally that much higher. And so for first-line investigational regimen, you're generally going to want to have something where we are familiar with the safety profile, where we know what the right dose of the drug is. And almost always, given the efficacy of ALK TKIs, usually we're going to be thinking about some sort of combination regimen where the standard ALK inhibitor, next generation ALK inhibitor, is already there as an anchor. And maybe you're trying to add something on to improve upon the efficacy or maybe the duration of benefit. So one example of a trial that was open in the first line setting, I'll just mention as an example, is one where we combined alectinib with a drug called bevacizumab. It was also called Avastin. And that's an IV infusion drug that works by inhibiting a protein called VEGF, where you're trying to modulate the tumor vasculature and maybe improve TKI delivery and CNS efficacy. And there, again, you're looking at alectinib, which is often used by itself as standard first-line option, right, as an anchor. And you're adding on a second agent like Avastin to try and maybe improve on overall efficacy or CNS efficacy. So that one is already completed, but it does serve as an example of kind of the combination regimen that I'm talking about. There have been trials that have looked at next generation ALK inhibitors combined with another targeted therapy like MEK protein inhibitor, for example, cobimetinib. And these trials are usually developed based on what we know from the science, right? So there's scientific data that suggests that if you block ALK together with MEK, that perhaps you can delay or forestall the emergence of resistance. And that's why these trials looking at combinations of ALK inhibitor with MEK inhibitors were developed. I know Dr. Yasser Elamin at MD Anderson has had a phase 1 study looking at ensartinib, which is another next generation ALK inhibitor combined with chemotherapy and bevacizumab. So all of these follow that similar theme of trying to add on something additional to the ALK inhibitor. And then on a similar kind of line of reasoning, but in a different setting, right? When you are already responding to an ALK inhibitor, there are also clinical trials that could be considered. And that goes back to what Colin was saying at the introduction, where he mentioned this idea of local consolidation therapy. And this is something we'll come back to probably towards the end of the session, but where you're really trying to do something additional once you've already responded to a first-line ALK inhibitor before progression occurs in hopes to delay that from happening. So absolutely, there are clinical trials that are ongoing and that can be considered before disease progression on ALK inhibitors. I would not think of clinical trials as a last resort. And what you heard is exactly right, which is that, you know, all of these trials have different eligibility criteria, right? And you might have to travel to a clinical trial. You want to be at a point in treatment where you do have some stamina and you're feeling relatively well and you are able to travel for a frequent visit schedule if needed, right? So I wouldn't try and postpone exploration of clinical trials as several steps down the line. This is something that you should absolutely think about and talk to your treating oncologist about at every step of your treatment, starting with your initial diagnosis. So I'm going to stop there.
Terrific. Thank you so much, Jess. That's great. So this is addressed to Jeff Sturm, who is remote. So I'm a patient and I think I might want to participate in a clinical trial, even if my doctor never mentioned the option of doing a clinical trial. How should I go about finding suitable clinical trials for me? And how do I make a choice?
Well, I would say the first thing that I would do is is connect with one of the doctors that's in the second opinion program. And Colin, I know you'll be talking about that later in the day. I work with Dr. Camage, Dr. Ross Camage, and certainly he has access to many of the different clinical trials that are available. But the other aspect of that is about educating yourself as to what's available. And if I can share the screen, someone needs to give me permission here. There are resources within ALK-positive that
it's coming, Jeff.
okay, that are available to educate yourself, that volunteers have put together to show what clinical trials are available by geography, particularly international, and then to educate you a little bit about how the science works and where the availability is.
I've been given the thumbs up that you can screen share.
There you go. So this is the ALK-positive.org website. Very easily accessible from anywhere in the world. And for this particular purpose, if you click on the research tab, there's a tab down here called clinical trials. And this is the spectacularly well done spreadsheet done by Ellie Urban that chronicles all of the available known clinical trials for not only ALK-positive non-small cell lung cancer, but other kinds of non-small cell lung cancer that where the treatment might be applicable or similar to what we use for ALK-positive. Note down here on the bottom that it's organized by geography. For our friends in Asia, there are a few available. Certainly in Europe, there are quite a few. You look down, there's 35 of them. I'm going to go to the Americas briefly and just look. It's further organized, the spreadsheet, by stage of disease. So as Jess was mentioned, some early stage, some middle stage. And here's where, for me, it starts to get interesting because I'm on lorlatinib at the moment. Second, third, and fourth line treatments. And the first one that comes up is the Nuvalent trial. So Ellie has detailed by trial summary, which gives a brief summary of the inclusion criteria. Tells you where it's open today, who the sponsor is, and gives a little bit of comment about the drug. So there's an identifier here. This is the clinicaltrials.gov click through. And if you click on that, you get to clinicaltrials.gov that gives you the complete official listing. So I'm going to click on the contacts and locations first. And I know this is important for a lot of folks out there. Right now, it's the Nuvalent NVL 655 trial is happening at Sarah Cannon in Nashville, but it's soon to open, thank God, in California, in Orange, California, where I live. I live in Northern California, but University of Colorado, University of Michigan, well, the Henry Ford Cancer Center in Michigan, pardon me, and MD Anderson. So I'm going to go back to the ALK-positive. If you read through, you get a quick summary, comes down and talks about the different arms. A little bit further are the eligibility criteria, who can join and who can't, and then the exclusion criteria that JP talked about. That's another resource that you can find easily from here. And another category down here is post standard of treatment. And there are quite a few interesting trials in this area that your clinical trials committee has really focused on and talked with: Imugene, Instill, Memgen, Gilead, we've talked to at length. Alethea Biotherapeutics is one that you're going to hear quite a bit about. Their clusterin inhibitor is one that Christine Lovely has worked significantly on. The Daiichi Sankyo Tropion Lung 1 is another clinical trial. Now from here, I'm going to go back to the ALK-positive page, go back to the research tab, and then hit the cutting edge clinical trials. And this is a collection of write-ups that I've done that came out of my utter failure to understand what any of these clinicaltrial.gov sites were talking about. The terminology was completely over my head. And I started taking notes on specific clinical trials because I had the interest, and discovered that if I took notes long enough, it actually was a cogent kind of description of what the trial was. So I thought I'd expand that to allow other people to share what I had learned. So we looked at the Nuvalent NVL 655 ALCOVE-1 trial briefly over on the other site. And this is the write-up that I did for the medical group, the medical committee members, and also the Facebook site, and soon to be published. Oh, perhaps it was already published on the newsletter, the ALK-positive newsletter. And if you want to educate yourself, which I highly recommend, about clinical trials, this is one place to do it in combination with the spreadsheet that Ellie has done. And when you look through here, I guess there are a dozen of them now. There's one Imugene that I mentioned. This is one run at Massachusetts General, which is what I call the combo trial that Jess briefly mentioned, with 3 different arms: crizotinib, binimetinib, and TN-0155. Explains the pathways for communication of those, etc. And I try to do it as a layman. I can only do it as a layman, and it requires looking up a lot of long words, but it should be understandable by most people. And if not, then your committee members are available at any time. I can keep going through these, but I think that's about it. Colin, I'll hand it back to you for open discussion.
Terrific. Thanks. So I will say that both Ellie and Jeff have provided the community with really incredible resources. It does take some time to look through this and become familiar with it, but your life literally depends on that. So make the investment, spend the time. It's probably more important than watching the baseball or the football or something like that. Make the investment, spend the time really reading, absorbing, rereading, absorbing, rereading, absorbing. I was diagnosed in 2016. I was a dentist. I didn't know anything about lung cancer. Everyone thinks I'm an expert. I don't know anything other than what I've read and learned and listened to and heard from other people. So invest the time in your future. Ray was going to ask this question, but since I'm standing up, I'll ask it for him. So this question is for Dr. Lin. What are some of the pros and cons for a patient to consider when deciding whether to participate in a clinical trial?
Great, thanks, Colin. So as you can glean from what you've already heard, everyone, the decision about participating in a clinical trial, of course, is not an easy one, right? Because there are so many factors to consider. Eligibility, what are the logistics, travel, what's the pace of change that you are experiencing in terms of your disease and symptoms, and then how does that line up with the anticipated time frame in terms of being able to start on a clinical trial therapy. And I would say ultimately it comes down to collaboration between your treating oncologist, the main kind of quarterback, together with the clinical trial team that you're meeting, as well as, of course, yourself and your family and loved ones. When we break it down to pros and cons, of course, the first and most important advantage that we're reaching for is that you're reaching for that hope that led to the development of the trial therapy, right? Of improving on either efficacy or tolerability of the existing standard treatment options. Usually, there will have been some compelling scientific rationale that resulted in the development of the trial and the investment of all the resources that went into launching the trial to begin with. So that hope is the most important kind of advantage that we're reaching for. In parallel, when you're participating in a clinical trial, you're really becoming a key part of driving advances in research and science. Without the participants who or parts of the trials of, for example, drugs like alectinib or lorlatinib, these drugs would not be where they are today, right? So you really become part of that motor that drives science forward. In terms of potential cons of participating in clinical trials, well, first and foremost, there's no promise that the investigational therapy will help or do better than the standard treatment. There's that uncertainty. So is there a possibility that you go through all of the investment of the time and the efforts to participate in a trial, and then afterwards, in hindsight, you find out that it didn't work against your cancer? Yes, of course there is. And that is, I think, one of the hardest parts about making the decision. And then another big disadvantage that plays in the decision making for a lot of patients and families is the financial resources and time that may be required, especially if you're having to travel out of state, for example, to participate in a given clinical trial. I want to come back to one point that JP emphasized earlier in this session, which is that you absolutely have the right to withdraw consent at any time. So when you find out information about a given clinical trial and you think, oh, this is the right thing for me to do, and you sign consent, that is not a final commitment. It is voluntary participation. If in the midst of the trial, for some reason, or even before you actually begin the trial therapy, but while you're undergoing screening process to see if you're actually eligible for the trial, let's say something else, some other information emerges or something happens where you and your family think, oh my gosh, I don't think going forward with this trial is the right thing for me to do at this time, you can pull out at any time. So I don't want anyone to think of going on a clinical trial as a walking into a door and having it completely closed behind you. It's always a revolving door and it can be opened again at any time. I did want to, I know we have Emily as one of our panelists, and I was hoping to have Emily give her kind of primary input on, because I know Emily went through the decision-making process and participated in a clinical trial. So really feel like the patients would benefit from hearing your personal insights on the factors that you considered and how you arrived at your decision.
Sure. So Jess is actually my oncologist, and she was the one who first told me I was ALK positive and presented clinical trial options to me. I knew when I was diagnosed with stage 4 cancer, I didn't know a lot about lung cancer treatment, but I did know kind of enough about cancer treatment to know that especially at stage 4, clinical trials were sometimes an option. So I sought that out right away to see if there was something that could help me in addition to the standard treatment. So I think when I was considering, so the trial that I'm on is a combination that Dr. Lin mentioned already. It's a combination of alectinib with cobimetinib, which is another TKI that works on MEK. And it was already being used in melanoma. So it was a drug that was already, the dose had already been determined in another cancer and the side effects were known. So I decided that after seeing kind of the preclinical evidence, so Jess talked to me about the work that had been done in the lab on this combination and done on mice, to show that this could be a good idea for me and it could be a good idea for patients first line to help the ALK inhibitor keep working longer. So I guess I considered what were these potential extra side effects I could get with this combination? Would they be tolerable? I was also happy that I would be getting alectinib, which was, I knew, the standard drug that I would have gotten anyway, and that would treat my cancer. Even if the second drug was not really having any effect, I would still be on the regular treatment. I was also reassured by, as Jess said, I could always leave the trial if the side effects weren't tolerable. If I didn't like how things were progressing, I could leave the trial and just take alectinib. And so I also, one thing I liked about the possibility of being on a trial is kind of a closer monitoring and a little bit of special attention, I guess, as a trial participant. And I found that this has been the case. I have a clinical trials coordinator who schedules my appointments, and really I think that's made things easier over time. My scans get scheduled for me. I don't have to make a lot of phone calls and figure all of that out. I'll usually have all of my visits back to back or within a couple of days, so I don't have to spend a ton of extra time. I would say that that's probably one of the cons for me, though, is I do have a few extra exams that I need to go through. Like I have to have an eye exam and I have to have an ultrasound of my heart periodically just to make sure that this drug combination is safe. So those do take a little extra time. Fortunately, I live in the Boston area, so I don't have to travel for the exams, but I know some other people on this trial do have to travel. And so that's a con of being on the clinical trial. But for me, the pros outweighed the cons, and that's why I decided to go on this trial.
That's terrific, Emily. Thank you.
Colin,
Really, go ahead.
Sorry to interrupt, Colin. I was just gonna come back to this important point that Emily made about how different clinical trials will have different assessment schedules, right? So depending on the trial, there will be distinct frequencies of scans, laboratory assessments, and then a lot of trials may require monitoring the heart function with a heart ultrasound or eye function with a formal ophthalmologic exam. And so it is very true that depending on the trial that's being considered, you may need scans. If you are on a standard treatment, you may be getting scans every 3 months, for example. But if you are on a clinical trial, at least for the initial few months, you may be getting scans every couple months or even every 6 weeks, depending on the trial. So that is a very important difference as well. And whenever you're going through the consent process initially, the trial team should be walking you through what that assessment schedule will look like if you are committed to going on the trial throughout the study. How often will you be getting scans? How often will you be coming to the clinic to see the provider? How often will you need to get blood draws? Those should all be reviewed during the initial screening process.
Thank you so much. And unfortunately, I think things actually looked like they were going to be becoming more accessible remotely during COVID, and then that's all gotten wound back since COVID's been supposedly over, which it's not, but that's something that we're hoping more and more of it can be done remotely as time goes by. Jess, I know that some treatments are not standard of care, but they're still commonly recommended by leading ALK experts, and not necessarily as part of a clinical trial. I'm thinking about things like local consolidative therapy, which we mentioned earlier, where when someone's got minimal residual disease, they go in and try to do what they can to remove whatever might be left. Or also similarly, if they've got just brain progression, but not body progression, and you increase the dose of the ALK TKI. Can you tell us more about options such as these, not necessarily just these, but just options such as these that you and some of the other experts quite commonly use? How would a patient learn about these options, and how would they gain access to these options?
Okay, great. Thanks, Colin. So taking a step back, here the concept is that if you go in and try to ablate the residual site of cancer after you've had great response to systemic therapy, what you're aiming to do is try to eliminate the nidus of cancer cells that could then go on over time to acquire additional mutations and gene alterations and develop frank resistance to the TKI, right? So that's what the concept of local consolidation therapy is. And it's really important to distinguish this from local therapy that's being used to actually treat a progressing spot. So as an example, if you've had a good response to a TKI for a long time and you have one adrenal spot or one brain spot or one lung spot that's growing and actually escaping the TKI therapy, sometimes your oncologist may say, you know what, the TKI is doing a really great job controlling the majority of your cancer, but this one spot is escaping. Let's try and address that one spot and get you more time on the TKI. So that happens as well, but that's an entirely different concept from what we're discussing here with Colin, which is while you're still responding for all intents and purposes, scans show that you are completely responding everywhere. There's no site that's growing. You're trying to do something extra on top of the TKI to see if that's able to get you more time on the treatment that's working so well for you. So this notion that local consolidation therapy could potentially help improve your progression-free survival, it's been now supported by several studies, both retrospective and prospective. One example that's cited often comes from data from Dr. Gomez and colleagues at MD Anderson, and this was published 2 or 3 years ago, where they did a phase 2 multi-institutional randomized study looking at either local consolidation therapy or just maintenance therapy or observation after a few months of first-line treatment. And this was not just in ALK-positive lung cancer patients, I want to say. This is in patient with any kind of type of metastatic non-small cell lung cancer. A few patients had EGFR mutation positive lung cancer. There were a couple patients that did have ALK-positive lung cancer. And in that study, just as an example, they found that implementing local consolidation therapy after a few months of systemic treatment did significantly prolong the progression-free survival and actually also showed overall survival benefit. So again, this was not a study specifically focused on ALK-positive lung cancer patients, but it's something that a lot of us feel very enthusiastic about because scientifically the concept is quite logical. Dr. Elamid at MD Anderson had the pilot IIT looking specifically at ALK lung cancer patients and integrating local consolidation therapy with brigatinib. That was the Bright Star study. So we're really looking forward to seeing the efficacy results from that. And then at Mass General, we do have an ongoing phase 2 trial that's for patients who have oncogene-driven lung cancer that includes EGFR mutation positive lung cancer, ALK fusion positive lung cancer, and ROS1 fusion positive lung cancer, where after up to about a year of targeted therapy, when we believe that there's been a plateau, a maximal response has occurred, then we go in and integrate stereotactic body radiation therapy to consolidate the residual site of disease. So this is still very much an investigational approach. And what I encourage is that if you are able to find a clinical trial that's feasible for you to access, I would always encourage that, right, in a clinical trial setting, because then that allows for us to collect a robust body of data that can be published and presented to the community as well. But it's something that you can discuss with your treating oncologist and other ALK experts as well if you're getting a second opinion. I believe we have Frank in the panel. Is that right, Colin, who's had personal experience with?
Exactly. I was just going to introduce Frank right after you were finished. A perfect lead in. So I would like to just say in regards to what Jess was mentioning, if you can get a treatment in a trial or outside of a trial, coming back to the stronger together theme, that the data, there is no data if you just go and do it on your own. what you're experiencing does not add to the data pool. And data is stronger together too. So if there's any chance that you can do that treatment in a clinical trial, even if it's a bit of an extra sacrifice, consider that your volunteer work, you know, rather than having to be on a committee or anything. You can just say, I'm adding to the data by doing it in a trial rather than outside of a trial. So do keep that in mind. Frank, I'm going to pass it over to you.
Yeah.
Everyone's looking forward to hearing your story.
Thanks. I'm just thrilled to be here 8 years after diagnosis, and thanks. A lot of what I attribute that to is not a formal clinical trial, but really getting a care team who was willing to be really aggressive and take logical approaches. So Dr. Lin talked about local consolidation therapy being a fairly logical approach. We did this in 2014. So that's, you know, I was a clinical trial of one, I suppose, with my group. They kind of said, well, let's throw the kitchen sink at you. And so I was diagnosed stage 4. I had metastases on my rib and vertebrae and some lymph nodes. And the standard of care at the time was crizotinib. But my wife and I were around 35 at the time, and we didn't know anything about lung cancer, certainly. I didn't know what staging was. So when they said stage 4, I was like, well, let's go get it. You know, here we go. And so when they told us that I was not a good candidate for surgery, we felt strongly that we should push back on that. And they said, okay, we can't really talk about surgery until we control what's going on in your body. And so this was the genesis of this local consolidation therapy. We started crizotinib. First scan was great. Well, as you know, the sites of metastases had really shrunk. The lung cancer tumor, or the lung tumor, was shrinking as well. 6 months later, more of the same. And by 9 months, we felt like we needed to ask the question again about surgery, because there was really nothing that we could see happening outside of that single tumor in the lung. And you know, I was seen at Mayo Clinic at the time. My medical oncologist was a younger guy. He didn't have all the bad habits that Dr. Muskavitch talked about. And so he said, look, I've got 5 thoracic surgeons. 3 of them I won't even talk to them about it, because I know they'll just throw me out of the room. Stage 4 lung cancer surgery. You're nuts. 2 of them, though, are worth having a conversation with. And that's what he did. And so after about 10 or 11 months on my first line TKI, we did do a video assisted thoracic surgery, a VATS procedure, to take out the left lower lobe of my lung. They found active cancer cells in there. So that was reassuring at the end of the day that we had done something that could meaningfully impact my outcome. I did subsequently go on to have, shortly thereafter, brain mets, which I attribute to crizotinib not protecting the brain. I suspect those were seeded prior to surgery. And that was my catalyst to switch to alectinib. So I've been on alectinib for 6 years now. 5 of those have been no evidence of disease. And again, I attribute a long run, you know, largely on this local consolidative therapy that is now it has a name. Before it was just the kitchen sink. So thanks.
Terrific. Thanks, Frank. So I'm going to have Heath pull up some slides about the second opinion program. So the second opinion program was set up back in 2018. And the idea of it is that we know that there's some oncologists that know a lot about ALK. And we know that the majority of oncologists don't know much about ALK at all. And when we're reading in the support group, sometimes, quite frankly, it's kind of horrific, some of the recommendations that are made. and maybe more so from internationally, but even within the US as well. So we've had some really generous donors that have contributed to the second opinion program. The idea is that we pay for a consult with an expert. You don't receive the money yourself, it goes directly to the institution where the oncologist works, but it's no cost to the patient. It's paid for by donations from generous donors. The program has been administered extremely well over all these years by volunteers. So thank you to the volunteers that have been doing that. And it is available to patients worldwide, and we literally get applications from every country in the world. Next slide, please. So you can see here, I've been having interviews and meetings with oncologists over the years, and oncologists that are really highly respected in their fields have all agreed to being part of the program. I have not had a single doctor not be wanting to participate. So many thanks to Dr. Bauer, Dr. Blakely, Dr. Camage and Dr. Gadgil, Dr. Lamb. Next slide, please. Dr. Lynn and her team, Dr. Lovely, Dr. U, and Dr. Patil. Next slide, please. So with the remote second opinion program, we advise patients to verify for themselves at the time of scheduling whether or not a remote consult can be done. The rules with this keep on changing. There's no way that you can ask us, does a certain doctor have the capability to do remote, because the answer yesterday was yes and the answer today is no, and the answer tomorrow might be yes again. So just make those consults yourself, and if you want to apply, that's the email address, Stephanie, and I won't try to pronounce it, Kratochwil at ALK-positive.org, and she has been lead and chair of the second opinion program for the last couple of years now. So with that, Nathan Plattner is clinical care coordinator for Dr. Camage's team. And if you'd like to just answer or sort of express some of the questions that you commonly hear from Dr. Camage's patients about, how do I get enrolled in this, and what's the, what do I need to do, and just talk about that until we've only got about 3 minutes left. But if you want to close it out, that'd be great.
Yeah, sure. Sounds like this is working. I didn't see a button on here, so I was a little hesitant as to whether this was going to work, but just addressing the slide you were referencing there, I wanted to say too that another good resource, probably dependent on the university, but I know that for our clinic, if you just go to like CU Cancer Center's website, there's a great webpage there covering a search engine for all clinical trials at University of Colorado. And that's a great resource if you just look into like specifically lung cancer and then what's ALK positive. You can scroll down and then see specific contacts at the university. So people like me will be listed on the clinical trials. So you can also just reach out to us and we can help coordinate your care. Otherwise, you may get referred by your primary oncologist to the clinic where you'd be working with a registered nurse to get an appointment set up and whatnot. Those are kind of first steps. From there, common questions like Colin was asking about. Some common questions are mainly, how complicated is the trial? What are the steps I need to do to enroll? And some of that was covered earlier by Dr. Lynn and everyone else. But speaking to it a little bit more, it kind of depends on the trial. So at this point, I think it's been pretty straightforward with ALK positive lung cancer, just because now I think ALK testing is so well incorporated into just normal screening and normal testing. But it used to be like Dr. Camage mentioned, where you'd have to send out tissue for testing specifically as part of a pre-screening portion. There's other trials that we have right now for later line therapy, like 4th, 5th, 6th line, et cetera, that are still kind of on the newer side, looking for other markers where you need to send tissue out for pre-screening. So that's kind of a separate set of trials. But right now, ALK trials are mostly such that you would just, once you're positive, and depending on the line of therapy, you would just go immediately into screening after reviewing your consent form. And then from there, usually takes a week or 2 or 3 weeks to get started. And then you would just kind of get started on your therapy from there. In terms of pre-screening, for example, if you were looking at trials outside of just ALK-positive targeted therapy, that takes a little bit longer if you ever encounter that as an option. Usually tissue testing would take probably two weeks to 3 weeks or so, where we'd have to collect it, send it out for analysis, get results back. And then at that point, if you were positive for a different marker, then you could start the screening process, which would then be, another 2 or 3 weeks before you start therapy. So that takes a little bit more time. But at least for ALK trials, it's pretty quick to get going once you know you're positive, I think. And then I guess other big considerations are the eligibility criteria. And really, that's not too much of a concern, just because you're going to be working so closely with your oncologists that they know your history so well that it's pretty quick to get in if that was going to be a consideration for you. But really, I think, like it was discussed before, the main, I think, question with that is just to make sure that that's going to be a safe treatment option for you based on, your health history and what you've been through, and really just making sure that that's just a good option, like a good safe option for treatment, if you will. And then another big question is, I know we just have a little bit of time left, but another big question is, how long can I stay on trial for? And that depends on kind of how long the trial has been open for, and then also just how you're doing on treatment. So a couple of endpoints for the trial are whether the trial is starting to close down, or whether the treatment is not working for you, or whether you just want to come off because of too many appointments or what have you. And again, everything's voluntary. At the end of the day, everybody just wants to do the best job they can for you and for your cancer care. So it's really a combined effort between a lot of different people. And that's kind of the beauty of it, is it's just a really kind of wholesome community, I suppose. And so I just want to wrap up and say, don't be afraid to reach out to people. Don't be afraid to bring up the question, oh, well, what about this option for care? I saw this online. Is this a thought that we could proceed with? Really just communicating as much as you can, I think, is probably the best step forward with everything. Even if it won't end up being an option for you, just always bring up the question with whoever you're working with. So anyway, thank you. Yeah.
Terrific. Thanks, Nathan. So I wish we had time for Q&A, but we don't. I want to thank Marc for being up here and just being on show.